Hello, and welcome to Health Talks. Today is October 25th, 2022. Yep. And it is Breast Cancer Awareness Month, as you are well aware. And so for today's Health Talks, we have Dr. Donald Huff talking about the importance of mammograms, the importance of CTs, ultrasounds, every imaging modality that is important when it comes to diagnosing cancer before it becomes a big problem. So if you would if you have any questions, just raise your hand, of course, the hand emoji on the screen, and mute your mics, of course, and hopefully you will learn a lot from this. Thank you so much. Dr. Huff, turn over to you. Okay, screen share. Let's see. Okay. Can you see the screen? I guess so. Okay, so let's start from the beginning. Here we go. Okay. And then the space bar or the down button.
All right.
Yep.
Well, thank you guys for joining us today. I've been asked to give a Jetliner's kind of 30,000 foot view of breast cancer and screening, and then also in preparation for next month's thrust for public health awareness, lung cancer and screening as well. So again, thank you for joining us. My name is Donnie Huff. I'm one of the radiologists here at Cookeville Regional Medical Center, and proud to be speaking with you today. We're going to start with breast cancer awareness and screening. First, let's just outline kind of why is this important and why is it an issue. Breast cancer, here are some statistics. I'm not a big statistics fan, but there's plenty of them out there. Basic risk for a woman of getting breast cancer in their lifetime is about 1 out of 8. That's why pretty much everybody knows somebody or has a family member who either has breast cancer and is fighting it or has conquered it, or has known someone who is. Lots of new cases. Over 300,000 cases per year in America. About a little over 40,000 women die from breast cancer each year in the United States. And at any given time, there's about 3.5 million women with breast cancer in America. So screening mammography is our basic tool for screening for breast cancer, and I often get asked the question, well, is it effective? Has it reduced breast cancer deaths? The answer to that question is absolutely yes. Here's a graph which is showing breast cancer mortality rates per 100,000 people for the last several decades. Screening mammography really took off kind of mid to late 80s. And you can see the definite downward trend in the graph there of mortality rates that have ensued after we've instituted screening mammograms. So it is proven effective. Trials have shown up to 40% reduction of mortality, and those are confirmed studies. Many studies out there show the benefit of screening mammograms. The 40% drop in breast cancer death is nothing to sneeze at. The benefits of the screening programs include finding cancers at an earlier stage, requiring less extensive surgery and less chemotherapy. And because they are found at earlier stages, treatments are more effective, and especially in getting cures for those patients. Why do we start screening at age 40? The risk of getting a breast cancer in your 40s for women is 1 in 6 breast cancers are found in that age group. And so therefore that's why we start at age 40.
So she's trying to get onto that. Okay, she probably needs to have the app. She's doing her phone.
Years of life saved is very substantial in that age group, and greater than 70% of the women who die of breast cancer in their 40s belong in that 20% bracket that are not being screened. So again, further demonstrating efficacy of screening. Starting yearly mammograms at 40 reduces cancer deaths from breast cancer by about 40%. And this is different than some of the other recommendations that have been proposed as different imaging schemes and timing of when to get and how often to get screening mammograms. So we started at age 40. That's the American College of Radiology recommendations, and that's pretty much across the nation how this is done. Like I said, there are some alternative screening guidelines out there. Everything has trended toward the American College of Radiology recommendations, which start at age 40. All the different recommending groups acknowledge the lives saved by beginning at age 40. And here's a graph showing a little bit of the differences in the percentage reduction in risk of dying from breast cancer based on some different algorithms of proposed different imaging schemes. Starting at age 40, we see about a 40% reduction in risk of dying from breast cancer. If we start at age 45 to 50 and then do every other year after age 55, only a 31% decrease in the risk of dying from breast cancer. So a substantial difference there, and we're missing some saved lives that we could have caught. And then doing every other year starting at age 50, even fewer breast cancers are found. So it is important, we feel, to start screening at age 40. Here's a graph just showing the years of life lost due to death from breast cancer. And again, a big preponderance of those years are lost basically in the prime of life in the 40s and 50s. So are there risks to mammography? I'll go through a few of those with you. All of these pale in comparison to the benefit of lives saved and the decreased mortality from breast cancer. When you get a screening mammogram, here's a chart just showing that kind of the general distribution of an average 100 screening mammograms of what happens with those reads. About 90 of those are going to be normal. About 10 of those, roughly 10%, will be asked to return for either additional mammograms or ultrasound to further investigate something that was seen on the screening mammogram. Of those 10, about 6 of those will be reassured after additional imaging of that finding that everything is okay. We don't have to worry about it. A couple of those will be asked to return in short interval follow-up, 6 months instead of a year. And then a couple of those will precipitate the need for a needle biopsy based on the findings and risk for cancer. Like I said, those risks of recall are minimal. It does produce some short-term anxiety, and that's not to be disregarded or downplayed. But when you hold short-term anxiety as a risk versus the benefit of saving a life from breast cancer, I think the distinction is quite clear on what should be done. So the callback letter that you get in the mail does not mean that you have a breast cancer. So don't just assume that when you get a letter asking you to come back for more imaging. It's just the next step in the process of working it up. So is there a risk of an overdiagnosis? Certainly any test has a risk of overdiagnosing. And there's been some discussion about, well, are we finding breast cancers that a patient would have lived their whole life and never known they had, meaning it wouldn't have affected their health directly or killed them. Obviously, that can't be measured directly because once we diagnose a breast cancer, almost everyone just immediately goes into treatment phase. How do we get rid of that? No one's actively going to sign up for a study to see, okay, if I don't treat this, is it going to be okay? Obviously, no one's signing up for those kind of studies. So we don't know for sure, but I consider that a minimal overdiagnosis as a minimal risk as compared to the risk of underdiagnosis or not finding cancers that do matter. So for average risk women, which is the vast majority of people, again, screening mammography, proven lifesaver, about a 40% reduction in risk of dying from breast cancer with regular screening, and we begin at age 40. It's effective because finding cancers early and before they have advanced or advanced staging or have spread elsewhere in the body. Those are the easiest ones to treat and to cure. So the benefits far outweigh the risk. In a subset of patients, women are at higher than average risk. And we'll go over a little bit of that here with you. There are known genetic mutations which can increase risk of breast cancer, BRCA1 and BRCA2 being the most commonly known. And those genetic mutations can significantly increase your risk of breast cancer, sometimes greater than 50% increased risk. So those are higher risk patients. We'll usually start screening those patients at an earlier age, start at age 30 with those, and can alternate that every 6 months with MRI. So you'll get an MRI and a screening mammogram once per year, alternating those so that they're not at the same time. Other risk factors for breast cancer, if you've had a history of breast cancer, you're at increased risk for another breast cancer. And so we'll be more aggressive with screening in that subset of the population. Occasionally we'll come into patients who've had previous chest radiation early in life, meaning before age 30, for treatment of lymphoma or something like that. So if you've had radiation to the breast or the chest previously, your risk is increased. And if you've had a previous biopsy, which was not cancer, but showed some abnormal signs or atypical hyperplasia or lobular carcinoma in situ, which, those aren't cancers, but they do increase your risk of developing a cancer, and we'll be more aggressive in screening in those patients as well. Breasts come in all different shapes, sizes, densities. Just go through with you a little bit. A lot of times these images don't project well when we try to scan them onto a screen like this, but rest assured, these are all being looked at on very high resolution monitors when we're reading them. This is just an example of the differences in breast tissue density, which we come across, ranging from almost entirely fatty up to extremely dense. As you can imagine, finding a tumor in the extremely dense breast or the heterogeneously dense breast is more difficult than it is in the almost entirely fatty or scattered fibroglandular density breast. And so not only does more dense breast tissue make it harder to see the cancer, greater breast tissue density actually is a risk factor in and of itself for increased risk of breast cancer. This is a graph, and I know it's probably projecting a little bit small for you guys, but some of the things we look for, if we find an abnormality, kind of how we'll describe things in a report. You may see breast composition like we just discussed. If there's a mass, we'll describe it based on some characteristics. We look for asymmetries, architectural distortion, calcifications can be an early sign of breast cancer, as well as things like skin retraction, nipple retraction, skin thickening, edema. And so those are some of the things that we look for. Everywhere in the country uses the BI-RADS categories for placing a mammogram into a specific risk bucket, if you will. And those go from 0 to 6. So every mammogram report should have a BI-RADS category and associated number on it. A BI-RADS 0 is those screening exams that we see something on it that we need to investigate further, either with repeat mammogram images with more specified images of that area, or if we look at it and we think, well, that looks pretty well, I don't need any more mammogram pictures, but I might need an ultrasound of it, or occasionally an MRI would be recommended. So that's the BI-RADS 0 bucket. If you get a BI-RADS 1, it's just a very normal breast. BI-RADS 2, we've seen something, but are very confident that that is a benign finding just based on what it looks like. So in the BI-RADS 1 and 2 buckets, essentially that's just your negative mammogram. When we get to BI-RADS 3, those are probably benign findings. Meaning we're very confident, but not absolutely certain that it's benign. And those are the ones that we can feel comfortable in looking at in 3-6 months. but aren't suspicious enough to really trigger a biopsy yet, and may never. And the longer we have demonstrated stability of those probably benign findings, the more likely that they will be benign instead of a cancer. So I'll put a plug in here for the importance of annual mammograms, because the more that we have to look back and compare to, it is easier to document long-term stability if we do make a finding and demonstrate that it hasn't changed, say over the last 5-10 years. So we know for a fact this thing is behaving and we don't have to worry about it. So it is very important. The more reference exams and the more regular you are about getting your screens, the easier it is to eliminate some of those unnecessary callbacks. When we get to the BI-RADS 4 and the BI-RADS 5 categories, those are the ones that we worry about. Those are the ones that precipitate a biopsy of some sort, either with ultrasound or mammographic guidance. Usually, on a rare occasion, a patient would go straight to a surgical biopsy, but most of the time they want a histology from a needle biopsy before they go to surgery. And so if you get a BI-RADS 4 or a 5, you can see the percentages there as far as the likelihood of cancer. BI-RADS 4 covers a very large swath of probability. So somewhere between 5 and 95% chance that could be a cancer. And that's just way too much of a spread for us to be comfortable with. And that's why we will biopsy those. BI-RADS 6 is for someone who's already had a biopsy and it is proven malignancy. We see those on occasion. I had one yesterday, and that is often when a patient is getting neoadjuvant chemotherapy, which is chemotherapy they will give before a definitive surgery is to be performed to try to shrink tumor and improve the success of the surgery. So we do see those occasionally as well. And the radiology presentation, not much without a few pictures. Again, these don't project all that great, but just an example of a mass there in that upper right-hand corner. That's a little speculated mass on mammogram. The bottom right-hand corner is a picture from an ultrasound exam showing those darker areas that you see there. Those are lesions which are BI-RADS 5 lesions, highly suspicious, and we would biopsy those. Just some more examples of masses and kind of things we look for. On the left-hand side of your screen, there's a couple of mammographic masses up top, zoomed in pictures down below. The one on the far bottom on the right, that's an area of architectural distortion. That's another sign that we look for on mammograms to see if there's any developing change in the breast parenchyma pattern. And you can kind of see all the speculated star-shaped areas radiating to the center point there. And I'll put a plug in at this point for tomosynthesis mammography as compared to 2D mammography and even before that, screening mammography. When I started training, everything was actual films. It was a screen film technology, and I had an actual X-ray film, if you remember what those are. Everything transitioned from that to digital, which was a huge step in technological advancement. We were able to see things we previously couldn't. We could zoom. We could change contrast settings in the breast digitally. So that was a huge step forward. The most recent, even more massive step forward, in my opinion, has been the advent of 3D mammography or tomosynthesis mammography. And that is performed with a three-dimensional mammogram through the breast. So it is arranged in slices. We're able to scroll through the breast. It's particularly helpful in dense breast tissue and heterogeneously dense breast tissue to be able to see behind confluent shadows, which might be obscuring something. And so that has been our biggest advance recently, and we have here at Cookeville Regional have transitioned essentially exclusively to using the 3D technology. It's just proven that much more effective. And so the amount of radiation from the 3D is no more than the 2D, and we just feel like it's a better technology and with no increased risk, really. And so Yeah, I think this one is loaded. If you'll watch the image closely, you can see that it is moving, and it is that's just a video of a scroll through a 3D mammogram where we come through and you see different planes of the breast come into focus. It allows us to see behind breast parenchymal densities, which are there to test if anything was hiding behind that. There's another case of that scrolling through a breast with the tomosynthesis technique, and if you'll look centrally there, you'll see a lesion, which is if you pause it on just the right size, you're able to better visualize the margins of it, give a more accurate measurement of it, and better localization of where it is in the breast. Couple images. I haven't talked much about MRI, but here are some cancers by MRI. Again, it's a 3D technology as well that we can scroll through. Here's an example where we scroll through. You'll see the markedly abnormal left breast there. If we do find something that is suspicious, such as in this case some microcalcifications, we can target those with a stereotactic mammographic biopsy, in which you'll see our needle advance there. We remove the calcifications, leave a little metal clip marking where that came from. Another way that we can do a biopsy, if we can see it on ultrasound, is we'll do an ultrasound guided biopsy. At the bottom is just a diagram of the needle. We'll place the needle underneath the lesion with ultrasound visualization and guidance. And then there's a little biopsy tray bay that opens up in the needle. There's a suction device that sucks part of the tissue down into that bay, and then an advancement of the needle then shaves off a slice of that. And we'll usually take 4 or 5 samples using that. So that hopefully you never need that, but that is how we do our biopsies if it comes to the point where you need one. So that concludes the breast cancer part of this. I am just going to move on to the lung cancer awareness and screening, and then at the end kind of wrap up with any questions or anything that anybody has about either topic at the conclusion, if that's okay. So just as breast cancer is a very important problem, lung cancer is also a very important problem that we need to be cognizant of and go about seeing how we can decrease death from it. Here's a graph just showing the different types and cancers in the males and the females, and then this is not the prevalence of the cancer. These are the cancers that are the #1 killers, is lung and bronchial cancer in both males and female. And if you'll notice in females, breast cancer shortly under that. So again, very, very important topics, and not a big stats guy, but it is often nice to know why is it we do what we do. Most patients who get diagnosed with a lung cancer are diagnosed with advanced disease. Here's a graph demonstrating that most breast cancers are advanced with advanced disease, either regional spread or distant spread, which makes it obviously more difficult to treat. Lung cancer can be curable if we diagnose it early. And this is a graph showing the different stages of lung cancer in regards to survivability at 24, 48, and 72 months. And so if you look at stage 1A1, about a 92% survival at 60 months, as compared to a stage 4, which is an advanced disease with distant metastatic disease, about a 6% survival. So a big spread there. So this just proves that finding it early before it has spread, very important. Lung cancer screening, what is it and why do we do it? Well, a test that is labeled a screening test, by definition, is done before the symptoms develop for that disease. Symptoms of lung cancer typically don't appear until the disease is advanced. So when you start having symptoms, it's often an advanced disease, and we would have loved to have caught it earlier. Up until recently, lung cancer screening hadn't been routine, just because lung cancer screening with chest x-rays, which were tried before as a screening technique didn't show any benefit in decreasing cancer deaths. However, we now have studies for CT lung screening that do show a benefit from CT lung screening, whereas the chest X-ray screening did not work. Here on your screen is one of our low dose CT lung screening questionnaire and order forms that you would go to your doctor and have a discussion with your doctor about your risk of lung cancer, discuss your smoking history, certainly discuss smoking cessation tactics that could be employed, and discuss your eligibility of whether you're a candidate for CT lung screening. CT lung screening is not for everybody. It's not an all-comers thing like screening mammograms are, just based on an age group, and then moving forward, everybody is recommended to have it. It's not the case with CT lung screening. It is proven effective in high-risk categories of patients, but it's not for everybody. And on the order form, you'll see we do CT lung screening ages 50 to 77 years. If you're currently a smoker or have quit within the last 15 years, or if you've smoked at least one pack of cigarettes per day for 20 plus years. And so we calculate pack years based on number of packs per day times the number of years that you did it. So any combination of factors that added up to 20 or more would be considered sufficient to qualify as a high risk and in need of lung screening. Again, just to give you a little history on the way that lung screening by CT has come about, very large clinical trial back in the earlier 2000s. Patients were randomized to chest X-ray and low-dose CT, and it was shown to have a significant and measurable benefit to those patients who were randomized to the low-dose CT category. Basically, we could prevent one lung cancer death for every 320 people screened, which is nothing to sneeze at, especially if you're that one patient. And compare that to breast cancer, we do about 1,300 screens to save one life from breast cancer. So both are efficacious, but again, just demonstrating the need for this and the saving of the lives. That was the first time where lung screening had been shown effective. So once they announced that, everybody gets kind of started on the lung screening program and trying to attack that problem. And again, here's just a slide showing kind of that high risk group that we try to target for our CT lung screenings. Again, if you smoke one pack a day for 20 years, or if you smoke 2 packs for 10 years, or any combination of factors that get you up to that 20 pack year mark, then you would qualify in that age group. It's also important that when you're getting a screening exam, that you don't have symptoms. If you have symptoms, you need to see your doctor. There may be more aggressive testing that needs to be done over and above lung screen. Simple fact, lung screens are great for looking at the lungs. They're not that great at looking much of anything else. It's heart, vasculature, other things in the chest. These are really great for looking at the lungs. But if you are having any symptoms, you probably want a more routine and standard CT with contrast for further workup, because these lung screening CTs are done without contrast, and there's a difference between the two. When we find lung cancer early, it is curable. I'll show you a case here in just a minute of a patient that was found here at our facility with a lung cancer and is alive and well today, probably because of that. Decreases your chance of dying from lung cancer, especially when we find things early. Lung cancer, big problem in America. There's about 7 million Americans that would probably qualify for CT lung screening, and we could save several lives if all those people did get screened. We are seeing an uptick in acceptance of CT lung screening among referring physicians and among our patient population, and so we are seeing those numbers increase, and that's a great thing. Risks of CT lung screening, there aren't really any that again, just like mammography, there are some risks, but they're very minimal in compared to the benefits. And so I'll go over some of the risks here. You can get false positives. We may see a spot that isn't a cancer, but requires additional testing and workup, but eventually proves not to be a cancer. So we do have false positives. Most of the nodules we do see on a CT are not cancer. Over 90% of them are cancer, in fact, but they may require additional testing or follow-up exams. So that is a risk, the false positives. Occasionally there are false negatives, meaning there's no CT evidence of the lung cancer there, and a negative exam no test is perfect. Doesn't mean you don't have lung cancer or can't get lung cancer. It's just that it's not evident on that scan. Some people worry about radiation exposure with CT. These are low dose CTs. They're performed with about 20 to 25% dose of a standard CT of the chest, similar to about 12 chest x-rays, similar to about 6 months of just normal living, natural background radiation. In regards to costs, not really a risk, but it is something to be discussed. Most insurance companies, including Medicare, now covering lung cancer screening just because of its proven efficacy, and in the big scheme of things is a cost saver for the health system. So here's just a graph kind of to put your mind at ease in regards to being afraid of getting a CT low dose screening exam. If your concern was radiation, it's right there in the middle and highlighted. So a mammogram is less than a CT lung screener. CT lung screener is less than your average background radiation, and they're all less than just a regular diagnostic CT. Here's just a picture kind of showing you an example of what you might see in the room. There's this CT scanner. You'll lay on that table and kind of go into the, we call it the donut, and that's where the pictures are generated. And most patients tolerate that just fine. Only on very rare occasion is claustrophobia in a CT an issue for us, because it is such a short exam, and you can see through the donut, so you don't feel closed in. So that's not really anything for you to worry about. So once you've had a CT lung screener, what does it mean? What do the results mean? If it's a negative exam, it means we didn't see any nodules or spots, no other abnormalities we're worried about. You'll just go back into the annual low dose CT scan recommendation grouping. We can see a positive exam, which is indeterminate for lung cancer, and then we can have a positive exam that is suspicious for lung cancer. And so, like I said, nodules are prevalent. Not all of them are cancer. Most of them end up not being, but there are characteristics we look for, and then we can monitor change over time with lung cancer nodule or lung nodules seen on screeners, just like we do with breast. And so the longer it sits still and behaves and doesn't grow or change in any aggressive fashion, the more comfortable we become with it. And so here's an example of a CT lung screener. This is an actual case here from our facility. And you can see there in that anterior right upper lobe, the mass, which would not have been known about, wasn't causing any symptoms, was just identified on a screening exam that was ordered by the patient's physician. We then further followed that up with a PET scan as the next level of recommendation. It did prove to be hypermetabolic on PET. And then this patient, I can tell you, had a right upper lobectomy, and is, as far as we know, disease-free today. So they were able to catch that early before it had spread anywhere else in the body, and were able to literally prevent this patient from dying of of lung cancer. Here's a picture of kind of just as we had BI-RADS categories for breast, we have lung RADS categories for lung screening exams. And we have different buckets of suspicion that we put things into, very similarly structured to the BI-RADS categories, in that 0 is incomplete. We need something additional. 1 is negative. 2 is benign. We look at it and we're not worried about it. Then we've got the category 3, which is also probably benign, just like in the breast world. And often those we'll put in that 6-month follow-up category. And then we get up to category 4, and those are the more suspicious ones, which either we will recommend even shorter follow-up time of 3 months. Occasionally, we can get a PET CT, as I showed you on that previous case, or if there are any other complicating factors or lymphadenopathy, or worried about vascular involvement, or we can do further imaging with contrast at that point if we need to. But just puts us on high alert that, hey, we've got to be aggressive with this nodule. Another case right there. So if you have a spot, meaning you don't get the 1 or the 2 category, we may recommend a 3 or 6 month follow-up, a low dose CT. We might do a PET scan. You might, based on the level of suspicion, you might be referred to a lung specialist for a possible biopsy. Different ways to do biopsies for lung lesions. We can do those with CT guidance, with percutaneous advancement of the needle with CT guidance, and sample the tissue that way. They can do bronchoscopy, go in with a scope, and biopsy it from the bronchial side of things, or on occasion, if it's not accessible from either of those and we're still suspicious of it, they can do an actual resection of that portion of the lung. So in summary, lung cancer screening with low dose CT decreases death from lung cancer. It's not appropriate for everybody. There is a subset of the population that's at high risk. Those are the ones we like to target. It is not a substitute for quitting smoking. So I would like at this point to let you know kind of how things operate here at Cookeville Regional. We do have tumor board meetings, which are multidisciplinary meetings of physicians from the different parts of the specialties of the hospital. We meet usually every 2 weeks, and it's usually represented by really whoever is interested in contributing, but radiology, pathology, surgery, oncology, just the whole spectrum of the treatment team. We get together and discuss cases, and so a multidisciplinary approach, it's helpful for all of us, because we all learn what the others are looking for, and what is important, and what is needed. What do they need what do we need from each other? So, and we'll go over actual patient cases that are being treated at our facility. We do that about twice monthly. I'd also like to let you know that you should not avoid getting these screening exams based on fear of cost, or feel like you're unable to pay for that. We do have screening mammograms and CT lung screening exams. They are covered by the vast majority of insurance that is out there, and so that barrier is removed. I will let you know that we do have a program at the hospital for help with mammograms in those ladies who are uninsured or underinsured, that has proven very effective as well. It does have some requirements as far as the need-based factor of it, but I don't want you to forgo getting your screening mammogram or your CT lung screener based on risk of cost. It really should not be a factor for you, and so would encourage you to both do this for yourself, do it for your family, and if you know someone who needs these, feel free to pass this word along as well. So turn it back to Laura.
Okay. Okay, so we have a few questions that have come through chat. Let me pull up the chat here. Okay, secondhand smoke, does that count toward eligibility for CT lung scan?
I don't know if it counts, like, as far as the, I will say this, secondhand smoke definitely increases risk. And I wished I would have been able to find you a case of a CT lung screener that was done in a patient that only had secondhand smoke exposure that was positive. So yes, it does increase the risk in regards to, does that meet the eligibility for insurance coverage? It's a bit beyond what I know, and would hate to say yes or no to that question, but would encourage you to discuss that with your doctor, so you can ask your insurance company in particular, you know, do they cover that? And also let you know, if you just walked in off the street with no insurance and wanted a CT lung screener here, I think it's $99.
Yeah.
So
yeah, it's very affordable. Yeah. False negatives on screening mammograms.
yes, false negatives do occur, and the fact that no medical testing program is perfect is evident every day. As far as mammograms are concerned, you know, tomosynthesis has really helped us in finding small cancers we might not have seen before, or seeing through more dense breast tissue. But no exam is perfect. And historically, between 8 and 15% of breast cancers can't be seen on a mammogram. So false negatives do occur. False negatives do occur with mammograms, as well as CT lung screening exams. Just because things are not always able to be seen. There's cancers that I've known for a fact where they were, and I couldn't see them because we saw it in some other modality. And so yes, no particular test is ever perfect, and there are false negatives, and those are things we do our best to minimize. But it is just a bad part of doing what we do.
Nature's beast.
Both the modalities are imperfect, and there's human elements involved as well.
Right.
None of us are perfect.
Right.
We just try our best.
So let's see, here's another question. Tennessee Breast and Cervical can also help with mammography costs. So there are different programs out there, like at the Pink Ribbon Fund at the foundation.
Yes.
And different, and Susan Komen does something program too, I think. Yes. To help with the cost.
Our fund here through the through Cookeville Regional is the Pink Ribbon program that assists for people who have trouble covering cost, and then there's also, if we find something on a screening mammogram and you came in through the Pink Ribbon program, if your concern is, okay, I'm going to get this with the Pink Ribbon program, but what if they find something that I'm going to be on the hook for trying to get all this care but no way to pay for it? The Tennessee Breast and Cervical detection program is something we would facilitate getting you plugged into and try to get you coverage.
That networking helps.
It does.
Yeah,
and
helps
then
the patient.
And then the Pink Ribbon program doesn't just stop at the screening level. If you're in need of help, we're not going to not give you help.
So talk about the difference between screening and diagnostic, because with any imaging modality that they do, any like colonoscopies are screening and diagnostic. So what's the difference in screening and diagnostic mammograms? Okay,
screening mammogram is someone who's asymptomatic, no symptoms, and is something we recommend annually at age 40 and thereafter. Diagnostic mammograms are, there are a couple of categories of those. They are patients with symptoms, and I'll take this opportunity to go over some of the things that you may be looking for in regards to symptoms. It is my advice to every woman, regardless of age, for your whole life, perform a self-breast exam at least once monthly, looking for things that are abnormal, looking for lumps, masses, things that you feel, skin changes, dimpling of the skin, nipple inversion, if that's never been present before, nipple discharge in the absence of a lactating mother can be a sign of underlying problems. Check your armpits for any lymphadenopathy. That's where the usual lymph node drainage is from the breast. And so as such, breast cancer will often spread there first. So those are things that I would want you to be looking for. If you ever find any of those things, call your doctor and say, I need a diagnostic mammogram, not a screening mammogram at that point, because we're actually trying to focus on a problem.
Right.
And so that's the difference between screening and diagnostic. The other category of diagnostics are those that if we found something on a screening and we're doing a 6-month follow-up, then that would be a diagnostic follow-up. Or if a patient has had breast cancer, we will do diagnostic follow-ups on those. And one of the main differences between that is diagnostic results are given to the patient on the day of, like the patient doesn't leave our facility until they know what our thoughts are and what our recommendations are and what the next steps are. And so whereas screening mammograms will have, we have a 24-hour turnaround or less on those, often less. The diagnostics we look at while you're here, and you have your results before you walk out the door.
Wow, that's awesome. And we are the only breast MRI facility in the region, right?
To my knowledge, yes.
Okay.
Yes.
Okay. And that's a benefit to the patient to get further diagnosis.
It is. MRI, I didn't spend a lot of time speaking about MRI. It's not as commonly needed, I would say, as far as in a workup, but we do come across situations, as I discussed, with patients who are in that high risk category of patients where we would want to alternate breast and MRI, or mammogram and MRI. And then on occasion, we do come across a finding on diagnostic mammograms where we're working up a cancer, or maybe it's a biopsy proven cancer. And the doctor before surgery needs to know, okay, is this involving the chest wall, or is this contiguous with any structures I'm going to need to be trying to save at surgery? So there are categories of patients where we do have that in-house and are ready to go with.
Wow. Okay. Another question: how is the quit smoking for 15-year criteria determined? So what if the patient was a two pack a day smoker instead of a per pack a day smoker?
How they came up with the 15 or the 20 pack year rule is I don't know. Every study that is designed is just kind of started, and they just pick some numbers and they start from there. And that particular study back in the early 2000s, that's how they structured that one. But again, if you smoke 2 packs per day for 10 years, or you could smoke 10 packs a day for 2 years, any combination of those numbers that'll get you up to that 20 pack year. That's just kind of the arbitrary amount of exposure that they kind of base that trial on. So.
And can you talk about the training that your techs go through? Because your read depends on your tech and how your tech gets the image. So can you talk a little bit about the education that they go through?
Oh, sure. All of our, we have excellent staff. Of course, I'm biased, but our techs, I'll put them up against anybody. They're very, very conscientious in their work, especially with mammograms. Placing the breast on the machine to get all of the tissue we can get in the image is very important. They're all specifically trained and certified in that. And so yes, technical quality of the study is very important. That's one of the human elements of the process. And then less tech dependent on the CT lung screener side of things, but we have excellent CT techs as well. And patients, I feel, have very, very good experience. Women sometimes get nervous about the compression for the mammograms. I've never had one, but I know our techs are gentle and cognizant of people's different tolerance of what they can tolerate.
Uncomfortableness,
we try to get the absolute best images possible. And so yes, I'm very pleased with our tech staff here.
So talk about a little bit about the technology that we have here at Cookeville too, that makes it different and makes it a whole breast and lung imaging program, because we have a breast center that is just for breast imaging.
Okay.
So talk a little bit about that.
Yeah, we have and on the breast side of things, the second floor at our outpatient imaging center is dedicated to that. That's where most all of that service is located. Has its own lobby, have our own staff up there. We have dedicated on that floor, dedicated mammo units. We have dedicated ultrasound unit up there. If we see anything that we need to take ultrasound of, right there, room right next door. You don't have to walk very far. That's where we do our ultrasound guided breast biopsies on the second floor up there. That's where we have our new stereotactic mammographic biopsy unit. And it's all centrally located right there. The MRI is downstairs. So everything is centrally located there and offered in one place. We have excellent team members here, as far as once we find something that is a problem, getting you to the next step. We have a nurse navigator that Amy helps our patients. She takes them from that point of the biopsy. We deliver those results. She and the radiologist will deliver those results directly with the patient. She walks them through the steps of making sure we get the next appointment that is needed, both with a surgeon referral, and get them an appointment with our cancer center doctors who are excellent as well. So we have surgery, we have oncology, medical oncology, radiation oncology, everything from the screening point to the end follow-up after successful treatment and being.
So everything here. Okay. So anybody else have any questions? Okay, well, great talk. Thank you for joining us.
Oh, yes, thank you for having me.
Thank you, everybody, for joining us. And stay tuned for the next subject, which is in November. It will be toward the end of November, I think. I'd have to send out the email, but just subscribe to our newsletter at our website, crmchealth.org. And please follow us on all the social channels. And thank you for joining, and have a great day.